Okay, so good afternoon, and thank you so much for coming out today. I am Dr. Regina Whitfield KC, board certified OBGYN with the Tri-Health community. Our specific group is called Global Partners in OBGYN. We have several offices. We are in the Rookwood location. We are in the Montgomery office. And then I do spend one day a week in our women's health area on the fourth floor in the Kenwood building, specifically addressing menopause and the non-pregnant patient. So we service our pregnant patients through our Montgomery office and Rookwood. So I was tasked with the responsibility of talking about hormones today, and I'm going to try very hard not to be too academic, but it's important to understand the changes that occur from becoming pregnant before the baby's born, where things are when the baby's born, how the baby girl progresses through what we call time before puberty, the prepubescent area, then puberty, and then we're now an adult, and how things change with pregnancy, and as we transition from the adult woman after childbearing, as we progress to menopause. So I'm going to try to limit that to about 30, 40 minutes, and you certainly let me know if I am getting too bogged down in the weeds. But I think it's really important for you to understand the anatomy and understand the changes that go on to try to explain why you are experiencing the things that you're feeling being pregnant women in preparation for childbearing. So at the conclusion of this presentation, you should be able to understand the natural development of hormonal changes in the body from birth to pregnancy to the postpartum period to the developed woman, and as you transition to the perimenopausal, menopausal period of life. We should be able to understand how you can navigate discussions regarding puberty with your child as they begin to experience changes, perhaps through nieces, and I did touch a bit on male anatomy as well. Secure general understanding just about hormones, and then what are some treatment options? How do you manage these changes that your body goes through as you are transitioning through life as a woman? And so, I'm sure regardless of your major in school, we all have seen the picture of the anatomy of the woman, and this just demonstrates the general anatomy. We have the uterus. The uterus is what houses the pregnancy. Some, at 6 and 7 years old, most children know that the baby is just in the belly and not really understanding that there are several organs within the abdomen. So as we get further along, we get more detailed about what's exactly in the belly. But with the female reproductive system, you do have the uterus. You have the uterus that is of 3 layers. You have the surface of the uterus called the serosa. You have the muscle of the uterus called the myometrium. You have the inner lining of the uterine cavity called the endometrium. You have the tubes that connect and communicate between the ovary and the uterus, and that is actually where the egg travels through, connects with sperm within the tube, and that fertilized egg travels through the tube and implants within the uterine cavity. It is the cervical canal that the baby travels through, and the end of the uterus, the entry into the womb, is the cervix. The cervix is what we see when we place the speculum in the vagina with your annual physicals, or should you present with any type of pelvic pain, vaginal concerns. And it's the cervix that thins out as thin as a piece of paper to 100% thin, and then it dilates to 10 centimeters to allow a baby to move from the uterine cavity through the cervix, through the vaginal canal, and out. And within 30 minutes of delivery, that cervix plumps back up, just like it was a little donut that it was beforehand. And ask your doc when you deliver to feel where your uterus is within 30 minutes. Within 30 minutes, that uterus is going to be beneath your belly button, if not at your belly button, and that is the organ that just housed the baby that you've carried for 10 months. So, quick facts. Eggs began their development when the baby is identified as a baby girl. At 20 weeks gestation, so if you ever had an ultrasound, so in speaking to the camera audience, our two attendees today are pregnant, so I may be focusing a bit of our communication with them so that they can identify what's going on, but at 20 weeks gestation, we have hormonal changes to the point where we're able to discern between the sex of the babe. At 15 weeks, everything looks pretty much the same and things continue to develop as part of embryology and the development of a babe. But at 20 weeks gestation, we should be able to see the differences in the anatomy. And by 20 weeks gestation, the ovaries house over 7 million eggs. By the time baby girl is born, those eggs have what we describe as they've undergone atresia, where some are just reabsorbed, some don't ever make it to the puberty stage, and by the time that baby girl is born, the ovaries together house about 2 million eggs. You are born with all the eggs you're going to have. There is nothing as a pregnant mom can do to change the number of eggs that you're born with. It is what it is, and we work with what we have in terms of being able to grow our family. At puberty, you have a number of those eggs that have continued to reabsorb because you're not ovulating prior to puberty, and by the time you reach puberty, you have about 300 to 500,000 eggs. And from puberty to menopause, we release about 400 to 500 eggs during ovulation. And as you get older, sometimes you release 2 or 3 eggs during one ovulatory cycle. Now, there is a communication between the brain and the part of the brain called the hypothalamus. The hypothalamus you can think of as I would say the parent, the grandparent of the hormonal axis. The hypothalamus has hormones that tell the pituitary to do a particular job. One of those hormones is called GnRH. GnRH talks with the anterior pituitary, so the pituitary has 2 lobes, the anterior and the posterior, and it talks with the anterior pituitary to let it know that we need you to release LH and FSH. LH and FSH then work with the end organs, our sex organs, the the ovaries or the testes, to produce another set of hormones that we're most familiar with, which include the estrogen, progesterone, primarily from the ovary, and testosterone. Now, believe it or not, we also make testosterone. Men also make estrogen and progesterone, but they undergo changes to provide the predominant hormone that men need, and then we and our ovaries, along with the adrenal glands, helps to produce the estrogen and progesterone and the testosterone that we need to bring about the changes that we need in order to mature, in order for us to ovulate, in order for us to have the physical changes that we experience as we develop. Now, this particular slide helps you to understand that the sex steroids or the sex hormones like the LH and the FSH, we have them, but at different stages of our development, you have a greater concentration, and we actually have a pulsatile occurrence to occur to bring the pituitary to a point where it's making more and more and more, which then moves us to the puberty stage. So this explains what is going on in the brain at the pre-puberty stage, where our sex hormone levels are low. The LH and the FSH are low, and therefore there is low levels of estrogen and progesterone and testosterone to cause changes at the level of our gonads, which are our breasts, which are our ovaries, and we don't see much in the way of change with our external genitalia. At the onset of puberty, there is a pulsatile change where we begin to make more LH and FSH. That then tells the ovaries to make more estrogen and progesterone, and with that spurt of hormones, we begin to notice change. And we have a level of what we call primary sexual characteristics, secondary sexual characteristics, and the description is described in the form of what is called Tanner stage. So if you have any children versus this is being your first babe, if you have children, you may have talked with the pediatrician about the different stages of physical change as the child goes from a pre-puberty stage to a puberty stage. And then by the adult level of hormones, it's just the, I don't know how else to describe it as you have, other than you have the adult level of hormones of LH and FSH. You've reached the stage where your organs are considered mature. You've gone through a number of changes, and you're now functioning as an adult. Now, as we described, the Tanner stages is a description that helps you to identify physically what are the changes that occur. And these changes can occur before you begin to ovulate. So children can begin to notice these changes as early as 8 years young, 9 years young. You're starting to develop breast buds, and the breasts become fuller. It's possible to notice a change in the labia of a baby girl, or just the area, fullness of the scrotum. With men, the testes begin to drop, and you develop enlargement of the penis. And so these are stages, or these are changes, but they occur in stages. And with primary sexual characteristics, as described, the penis and the testes begin to enlarge. Sperm starts to be produced. You begin to have secretions. From a female standpoint, ovulation occurs. And that's when ovulation occurs and you have your first cycle. That is the hallmark of entering into puberty. Now, the average age in the U.S. can be about 9-10 years young, but sometimes young ladies begin their first period as early as 8. My first period was at 11, and sometimes your first period doesn't occur until age 14. Things begin to grow, and the point at which you begin to ovulate, you have the ability, or the young lady has the ability to get pregnant and have a child, whether they know what's going on or not, whether they know what they're doing or not, as they are evaluating and exploring anatomy. Secondary characteristics for the female is you begin to have more breast development, you begin to develop pubic hair, hair underneath the breast, odor changes, and then you continue to develop. Tanner stage 5, you're an adult, adult-sized breasts, or just the anatomy appears to be consistent with a young adult. Now, in terms of hormonal changes and how they impact our end organs. Now, to be honest, I really didn't understand clearly how things work together in concert until I got to medical school. In college, they give you these graphs and these changes separately, and I didn't realize that all of them are happening in concert. They just describe them as happening differently or at different points in time when they actually happen simultaneously. And so if you look at the table here, this is actually, remember, what's going on at the level of the pituitary. So the pituitary is telling the end organs, the ovary, to the FSH levels begin, it's a steady level until there is a bump here at the time of ovulation. Estrogen also has a slight rise, a gradual rise, and then what's called the LH surge occurs, and that's the moment where you ovulate. FSH and LH are responsible for letting the ovaries know that we need to make estrogen and progesterone. And what happens at the level of the ovary is described as follicular phase, luteal phase. At the level of the uterus, there are changes to occur as well. It is understanding this that helps you to know when is the most fertile time to become pregnant. You cannot become pregnant just any time of the month. It's within that 3-day window of ovulation. The concept of ovulation is when the egg is released from the ovary, okay? So estrogen's job is to build the lining in preparation for receipt of a fertilized egg. At the same time, the ovary has these eggs, these 400, 500 eggs that we release each month, but they are actually housed in what we call follicles. The follicles are actually at different stages. So when it's really quiet and they're not active, they're called antral follicles. They're in the quiet stage. But as estrogen levels begin to rise, one of those follicles jumps ahead in growth compared to the other antral follicles, and it becomes a dominant follicle. What we consider to be a mature follicle is about 20 to 22 millimeters in diameter. And this information becomes important as we're trying to work to help a patient to become pregnant. This is what a reproductive specialist goal is to try to get. And as part of a reproductive specialist job, they are to create this symphony between the ovary, the uterine lining, and that's where those hormone levels come in to have things perfect at the exact moment, so that when ovulation occurs or the rupture of that egg, the lining is where it needs to be, hormone levels are where they need to be, the estrogen level and your lining is where it needs to be able to receive that fertilized egg. Now, once ovulation occurs, you literally have within 3 days, 72 hours, for that sperm to find the egg. If you, or if anyone in the audience is really working on trying to become pregnant, this is how those ovulation kits work and how you interpret the ovulation kit. They want you to make sure that you have sperm in place within that window of ovulation. Interestingly enough, sperm can live within the genital tract 3 to 7 days. That is why you have the instructions to say, this is the fertile 7 to 10 day window, and you may receive instructions on having sex within this 10-day window. If you have sex and sperm is present before the expected time of ovulation, that sperm is present, ready to hop on that egg as it is released. If you have sex during the day of ovulation, if you have sex a little bit after the day of expected ovulation, you are flooding the system with sperm, where we only need that one sperm to find that one egg to become pregnant, okay? At the same time, estrogen at the level of the uterus, the estrogen's job is to thicken that lining in preparation for fertilized egg. And if you notice here, at the LH surge and that egg is released, progesterone levels shoot up. Estrogen's job is to thicken the lining. Progesterone's job is to maintain the thickness of the lining, waiting for that window and that message. Are we pregnant or are we not? Okay? If the body gets the message that you're not pregnant, these hormone levels begin to fall, your lining gets weak, and you have a period. You shed your lining. If you become pregnant, this progesterone level will stay elevated to support that lining so that the fertilized egg can nestle in and get comfortable and snuggy in preparation to implant and become connected to the uterine blood supply. And that is called placental or implantation. And from that is when the placenta forms. Now, at the level of the ovary, prior to ovulation, that cyst that we call the dominant follicle is in the follicular phase. It hasn't ruptured yet at ovulation. The moment that it ruptures, you enter into the luteal phase. As we get ultrasounds to evaluate the lining of the uterus, and you may have seen a report that says, hey, the lining is thickened, please coordinate with where the patient is in her cycle. Because depending on where you are in your cycle, we want it to be 18 millimeters thick. We want it to be thick so that the fertilized egg can nestle in. This information helps us to understand whether the uterus is in sync with the hormone levels to determine luteal phase defect, which could be something that is contributing to your inability to get pregnant because the progesterone level isn't where it's supposed to be, and sometimes in pregnancy we give you some hormonal support of progesterone vaginally to keep that lining thick until the placenta is made, and then the placenta picks up the responsibility of maintaining level of hormones. Isn't that amazing? I mean, all of this it's a perfect symphony, right? I explain this during my appointments because many times we think cysts are bad. Oh my gosh, I'm having this cyst and I'm having this cyst pain. But guess what? The purpose of pregnancy, birth control's job is to prevent this process from happening. Birth control's job is to prevent this cyst from forming. So when you're on birth control, you may not feel that you're ovulating. You may not feel this monthly discomfort on one side or the other because the purpose of birth control is to prevent ovulation. But the moment that you stop taking the medicine, all of a sudden you're like, what is that? Is there something wrong? It is a common conversation when patients have been on birth control and they're now ready for sterilization, or I'm ready to come off birth control because I'm ready to grow my family. And they're trying to figure out, why is all of a sudden I'm having pain this month and over here it was last month? What in the world is going on? It's the natural process of the ovary to produce that dominant follicle for ovulation. And when you were on birth control, it wasn't happening, so you didn't feel the pain. Okay? Birth control also helps to keep your lining thin because you don't see the wax and wane of the hormone levels. And so when you're on birth control, your cycles are lighter. They may be a little shorter. You come off birth control, you're like, oh my gosh, where is all this bleeding coming from? It's just, you go back to your natural process, your natural hormone levels and your natural flow. Any questions about that? Okay. So, guess what? You do not have to remember all of that to have a conversation with your new babies or your new baby girl when they are noticing changes in their body. What you can do is say, hey, I'm noticing some changes. I don't know if I am prepared for this conversation. I think she needs to talk with a gynecologist. Now, pediatricians will go over these things, but if we're starting to think that we want to have a conversation about contraception, they may then refer you to your gynecologist to have that conversation. Most gynecologists, obstetricians and gynecologists begin seeing patients as early as 12. Now, an exam doesn't, or a gynecologic visit doesn't mean we're going to do an exam. We can just say, hey, we'd like to meet you. We'd like to help you answer any questions you have, get a better understanding of the changes that are going on with your body, what's normal, what's not. Discussions about tampons. Is tampons a good idea? What about pads, different pads? I like to swim. How do I navigate that when I'm on my cycle? I'm having difficulty placing the tampon. Is that normal? All those things we are happy to discuss, and you can certainly be present. Oftentimes when I get moms who want us to have a conversation, I usually will ask, what is it that you would like me to cover? Because we could talk all day about something that she's not even interested in, or she's not even ready for, or she's not even at that point, to even have a conversation about the penis, and the penis is still, ew, that's nasty. So it's up to the mom to really set the tone of what you would like us to cover at that appointment. As the patient becomes more interested in the opposite sex, we can pivot the conversation to something different. It was a young patient that introduced me to the image button on the search engine when you search things for Google. I was still in the printout stage and trying to print out handouts. They were like, just hit the image button and then you can see the pictures. I was like, wow, I don't even think I realized that image button was there. And I have been in heaven ever since. So just to let you know, you're not alone. It's okay for you not to know this level of detail. That's why we go to school to discuss this. And at that appointment, we really just help them to understand whatever they're experiencing, it's normal. The fact that you are experiencing something different from your good girlfriend is okay. Everybody develops at different levels. We typically do not have a pelvic exam. We talk about the concept of anatomy. We talk about what exactly is a pap smear. We have had a change in new pap smear guidelines and recommendations, and I can certainly answer those questions for you after the presentation. We talk about vaccinations. We talk about, whatever that they're interested in talking about. If they're not ready, sometimes patients aren't comfortable talking about things with the parent in the room. And we will certainly ask that question, and parents are happy to step out. There are some parents who say, no, I'm not stepping out. Whatever you need to talk about, I could be here. And again, at the end of the day, it's really the parent that sets the tone. We do have laws on the books that protect, patients when it comes to their reproductive rights. We do have patients who have the right to come in and talk about birth control without the parents knowing, but I do, and I applaud them when they want to come in to have this conversation. But I do help them to understand that as long as you're on mama's and daddy's insurance, it's going to show up one way or another, probably like an explanation of benefits, and they're going to know, what you came in to talk about. So whenever you're ready to have that conversation, your parents are there for you. That's why they've sent you in to have this conversation. They love you, they support you. But do know that you have a level of privacy, and we want them to feel comfortable having a conversation about whatever they're interested in. We talk about STIs. We help patients to understand that you can get STIs in the mouth. You can get STIs in the throat, in the eye. I've had patients who really want to preserve their virginity, and in their mind, virginity means nothing in the vagina. They're having anal sex on a regular basis. So it really just depends on, the education, help the patient know you still can get sexually transmitted infections, and there's nothing that's gone in the vagina. I don't know where our educational system is in having these conversations, but I think we've kind of cut some of that curriculum out. All right. So this is just a recap in terms of, what is it that we talk about at the appointment, a general well women's visit. As you all may recall, when you come in for your annual physical, we go through preventive tests. We talk about your breast exam, your pelvic exam, any history of abnormal pap smears, abnormal mammograms if you're of age, any sexually transmitted infections, any concerns with your cycle, and we talk about, having a multivitamin on board, bone health, sexual health. And when to see a doctor when you think you might be pregnant. I would say there is no sooner time than, hey, I think I missed my period, what should I do? There's a blood pregnancy test called HCG that is more sensitive in the blood than showing up in the urine. I encourage you to speak to your body if you know your body best. You live with you every day. If you think you might be pregnant, but yet the pregnancy tests at home are still negative, give us a call. We can do a blood pregnancy hormone level called a beta HCG. That HCG level has to be at least about 25 or 30 before it becomes positive in your urine. Whereas at the blood level, if it's greater than 5, you're pregnant. It's just very early. What are the hormonal changes and effects that occur in pregnancy? So we've already talked about estrogen levels are high, progesterone levels are high. HCG stands for the human choriogonadotropin, and that is the blood pregnancy hormone level. Every hormone has a job, has a responsibility. We have the HPL, which is the human placental lactogen, and it has a job. You have relaxin, you have prolactin, and you have oxytocin. So estrogen's job is to help with maternal and fetal growth and development. That's being able to accommodate the uterus getting larger, the breasts become larger. Estrogen can certainly have an impact on mood. Progesterone, again, progesterone's job is to maintain the thickening of the uterine lining. It can contribute to mood changes. Oftentimes you have a lot of breast tenderness as you get further along in the pregnancy. But the great news is once the placenta is made in the 12th week, then progesterone levels in your bloodstream may taper off a bit because the placenta is now picking up that responsibility to maintain for the rest of the pregnancy. HCG levels are at the highest in that first trimester, and it's the high HCG levels that contribute to the nausea and vomiting that you have. And as those levels kind of taper off a bit, the nausea gets better in the second and third trimesters. The HPL's job is to help the placenta to do its job in developing the vessels of the placenta so that it can provide that exchange, gas exchange, food, nutrients to the baby through the placenta, through the umbilical cord, and you have that exchange at the level of mama's bloodstream, the placenta, and the fetal bloodstream to help baby to grow. There is a hormone called relaxin, and relaxin helps with relaxing those ligaments, relaxing those joints in preparation to accommodate a baby coming through the birth canal. And that includes your pubic bone. Sometimes as you get further along, you're like, oh my gosh, I need to get this baby off my bladder, off my pubic bone, because it becomes very sensitive. And all of that is normal. Another thing that progesterone does is it relaxes some of those ligaments as well. And we actually have sphincters that help to keep food moving in a forward direction. And in pregnancy, because you have progesterone levels high, the relaxin is high, the sphincter that keeps food in the stomach moving forward relaxes. And now we have food coming back up, acid coming back up, which contributes to acid reflux the further along you get. The other thing in pregnancy is things move more slowly through the system. So that is food going through your stomach, going from your esophagus to your stomach, the emptying of the stomach. That's why you stay full longer. That's why you get full with less food than what you would typically eat. And then as you get further along, you got this big baby that's pushing up on your stomach, which contributes to almost like an obstruction because it's in the way. It's not able to, the bowels aren't able to do what they need to do. That contributes to the constipation. Pregnant women are at an increased risk for developing gallstones because the gallbladder empties more slowly. The gallbladder's job is to break down fats. The ureters, bringing urine from the kidney down to the bladder, empties more slowly. And then you have this compression effect of the uterus pushing on the ureter and the ureter connects the kidney to the bladder. And so you're at risk for urinary tract infections, you're at risk for kidney stones. And so all of these things work together to explain the symptoms that you're having the further along you get. Is this which pregnancy is this for you? This is your second?
Same.
Okay, so you might have heard of a medicine called Pitocin.
Yes.
Okay. Well, so Pitocin is a medicine that we give in order to get your uterus to make stronger contractions. But believe it or not, the natural Pitocin is made by your pituitary, and it's called oxytocin. So if you have experienced breastfeeding, you're like, oh my gosh, I almost feel like I'm in labor again because I'm having these contractions. It's the body working in concert to get that uterus back down to a pre-pregnancy size. It squeezes, you contract, it helps to expel any blood that you have in the uterus, it gets that uterus back down to a pre-pregnancy size, and it helps with milk ejection. So it helps with baby being able to get more milk out of the breast, okay? Prolactin helps with milk production. It helps with the maturity of the mammary glands and helps to get that milk produced, but it's the oxytocin that helps with the milk ejection. And all of that works in concert when you're breastfeeding to get that uterus back down to a pre-pregnancy size. Amazing. All right, so we've had our babies, we are done, we are moving and shaking, and we're enjoying life, and all of a sudden you're like, I turned 40, and everything just started falling apart. What is going on? Well, we have hormones that begin to change. The ovary's job is, again, to produce that egg every month. Over time, ovarian function begins to decline. The number of eggs that you have begin to dwindle. And as estrogen levels fall, the benefits of estrogen begins to show. They begin to show in everyday life. So a quick snippet about menopause is there are several stages before you get to the concept of menopause. And menopause means you stop ovulating. There is no more cycle. You stop menstruating. But before you get to that point, you have a slow decline in the quality of eggs, the number of eggs, and believe it or not, the quality and the decline of those eggs begin at 30. So our most fertile time is under the age of 30. But we recognize in the world that we are delaying the growing of our families until after 30. The wonderful thing is that technology is available, and I probably should have put a slide in here that transitions us from postpartum to the menopause stage, is that we can now harvest eggs, freeze them, put them on the shelf for later when you're ready to have a family, and it extends your fertility window. Okay, so as eggs and the number and the quality begin to decline, it's a shallow slope. As you enter into your mid-30s, that slope gets a little steeper. By 40, you're losing that 300 to 500,000 number of eggs because that concept called atresia and just reabsorbing. Not every egg that you have at puberty is going to make it to ovulation or make it to a monthly release. Some of those follicles begin to reabsorb. And so as you age, that rate becomes a little quicker. And it becomes more challenging to try to get pregnant later in life because you have fewer eggs to work with. So in the past, in the early 2000s, we could only freeze a fertilized embryo. And we weren't at a point where we can freeze an egg and the egg survive thaw to then pair with sperm. We've been freezing sperm forever, right? But our eggs, the technology wasn't there to allow us to be able to freeze eggs. We could only freeze once you paired it with sperm, it becomes an embryo, and then you freeze it at a certain stage. All of that happened when I was in med school, and I was like, oh my gosh, I'm in my 30s. I went to med school at 30, and I said, can you just take a whole ovary? I don't even know who the baby daddy is gonna be by the time I finish. I'm not even dating anybody. And they said, unfortunately, We're just not there in terms of technology. We cannot just take your ovary. We cannot give you the hormones to harvest your eggs because we can't freeze the eggs. They crack before, we're able to thaw them. So we now have the ability to freeze eggs. And I began to have this conversation with ladies in their 20s. The late 20s, 30s, having children is far from most of our patients' minds, but I am quick to let them know. If we can travel the world, this is the most traveled generation. I mean, they just hang out in Greece, for whatever. I just went with the girls, we went to Brazil for the weekend. If you can afford that, you can afford these red bottom shoes and all of this name brand and purses, you can invest in your future fertility. You can take the stress off of choosing the wrong person because your time is running out and you need some sperm to have a baby. You don't even have to deal with that anymore. You can pay to freeze your eggs. You can put them on the shelf. And when you're ready, you've seen the world, you've done all that you want to do, and you're now ready to settle down, you can unthaw 1 to 2 eggs at a time, fertilize them with your partner for life, and put that fertilized embryo into your uterus, and then have a baby. Isn't that wonderful? So many folks don't have that conversation. I think when patients come to their appointments, they're looking to us to provide that education. And I am a strong proponent of having that conversation. And if it's not something that you're thinking about right now, at least you know that that option is available. So in terms of menopause, again, the perimenopausal stage, things that you can begin to develop and notice is, the first thing is that you're noticing menstrual changes. When you were younger, your cycles are like clockwork. They always come on the 9th of every month. I only bleed 5 to 7 days, and I know when things are out of whack, something's going on. But as you get further along in life and those hormone levels begin to fall, you begin to run out of eggs, egg levels begin to fall, the quality of eggs, the first thing you will notice is some menstrual changes, a possible skip of your cycle. The first day of full flow is spacing out where you're like, wow. The normal variation in terms of a cycle is every 21 to 35 days. And maybe when you were younger, they were every 24 like clockwork, and now they're every 28. That's a change in your baseline, but it's a reasonable change. When you start having periods every 60 days, that is not normal, but that may be your new normal after we've ruled out other hormonal changes that can explain a spacing out of cycles. When you're breastfeeding or when you've had a babe, your cycles, you don't have one because the prolactin levels are high. If you have breastfed, you may have noticed, I breastfed for a year. I never had a cycle. That's another whole hormonal axis description, but when prolactin levels are high, ovarian function is suppressed and you don't have periods. The moment that you begin to wean the babe and babe's eating more and you're pumping less or you're making less breast milk, you notice that your ovarian function returns and you start having periods again. That is normal. It does not mean that you cannot ovulate randomly in the absence of a period while you're breastfeeding, because you can. And we've seen that too. Come in, oh, I've been breastfeeding for 3 months and all of a sudden I have this wave of nausea. What in the world is going on? They're already 8 weeks pregnant. And they're like, how is that possible? And I've not seen a drop of blood. How is that possible? It is possible. So, that's another conversation at your postpartum visit and in terms of, what your plans are in growing your family. But to get back to menopause, common symptoms of menopause, you become more anxious sometimes. Your mood becomes a little down, or you become, you have a little bit more brain fog. You're not able to remember the things that you used to remember. There are over 40 symptoms of menopausal changes. But guess what? Everybody's different. Not everybody's going to experience the same thing, and sometimes you just stop having periods altogether, and that's it. You may have an occasional hot flash, personal summer, as my mother would call it. You may have some vaginal dryness, but what our typical approach is with managing menopausal symptoms is identifying what is the worst for you. We want you to have a better quality of life. Sometimes it's a change in diet. Sometimes it's a change in exercise. There are some other things that you can do short of just being put on medicine to help with the changes associated with menopause. Some of the treatment options with the menopausal symptoms can be hormone therapy. So that is another whole lecture about hormone therapy, how things have changed from the early 2000s when we had the studies that gave us concern and pause with increased risk of breast cancer, and why was that, and how things have changed since then. You have non-hormonal medical therapy. Sometimes acupuncture helps with some folks. Maybe therapy. Sometimes, we find other ways to address stress. Maybe it's just having a conversation, having somebody that you can talk through some things with. Again, if your biggest concern is weight gain, we can do some things regarding weight. Maybe seeing a nutritionist, adjusting some other things. Maybe it's some other hormone levels that need to be tweaked a bit that make you more, that help to boost your metabolism to be able to lose weight. Sometimes there are nutritional supplements that can certainly help with hair thinning or changes with the levels of concerns for hair, vaginal dryness, and then sometimes if there's a concern that organs have become lax, they're not as strong and taut as they used to be, sometimes physical therapy, pelvic floor therapy, or sometimes surgical management is necessary to address whatever that concern is. I just wanted to recap in terms of medical terminology. The term atresia or ovarian reserve depletion is how we get from 7 million eggs to 5 million eggs to 300,000 eggs to we have run out of eggs. It's a natural decline in the number and quality of eggs as we age. The term menarche is described as your first period. Menopause is when you have had your last period. Ovulation is the natural development or plucking of that egg from that dominant follicle that occurs usually around the halfway point of each month of your cycle. The term perimenopause is the transitional period between or before menopause. You may have heard the term prepubescent, and sometimes people use that as an insult, prepubescent person. But that's the point in time right before puberty, right before hormone levels give you that spurt and you have your first ovulation. And then we talked about puberty, and we talked about the Tanner stages to describe the changes that go on with the body when puberty occurs. But puberty equals to you are producing mature sperm, and you have mature eggs with the ability to become pregnant, whether you know what you're doing or not. So if you're noticing that your little one is starting to get breast buds and they're more developed than the average fourth grader, it's never too early to have a conversation. It doesn't mean that you're giving them permission to go out and just live it up, but we want our young people to understand sticking it in just a little bit is all it needs to have a baby that you're like, I don't even know what's going on with my body, how did this happen? And in my opinion, it's better to have a conversation on the front end so that they're well aware, not again that you're giving them permission to have sex. We have menopause services available at TriHealth, and if you scan that QR code, it puts you into the website where you can make an appointment. We recognize that addressing menopause is not something, in our head that we're imagining things. We have a separate service line to address women who are undergoing those changes. And if you know of any woman who wants to have a conversation, wants to meet with a provider, those appointments are strictly referral appointments. It's not a physical exam. We're not trying to take, that young lady from their routine GYN doc, but it does take time to tease out, have those conversations, try to figure out, what's going on, what's the most important. And as you know, many of our appointments are like 15 minutes. Your OB appointments are like 10 minutes. There's not a whole lot of conversation that you can have with that short period of time. So our menopause appointments are 30 minutes, where we're focusing specifically on what changes patients are experiencing, and we address them accordingly. And then we also have the link there. I believe that is it. I could talk on and on about OB and Gen. I enjoy what I do. I've been at TriHealth almost 17 completed years next month, and I'm still enjoying it. I still deliver babes as well. So again, I am Regina Whitfield Casey, board certified OBGYN, and thank you for your attention. Yay, thank you.